as far as where it began 40-something years ago to where we are now. And what today is focusing on is something that I look forward to doing more often in the future with regard to even improving upon the technological management of acute cardiorespiratory failure using a hybrid approach utilizing ECMO with a percutaneous left ventricular assist device. And I'll share with you how it came about and what we look forward to doing in the future, because I think it may become something to strongly consider for, particularly for myocardial recovery, where traditional veno-arterial ECMO has its limitations. So if this will run, let's see. Yeah, so this is the traditional video of veno-arterial ECMO in the adult. It's put in through the femoral artery and the femoral vein by way of cannulas of different sizes. So depending upon the patient's body size, BSA, BMI, we'll use different cannulas to achieve adequate blood flow to somewhere between 4 and 6 liters per minute. So depending on size, you might use smaller or bigger cannulas. And if you saw in the video, the flow into the artery is retrograde. And it's going to come back to us when I describe to you a better approach whereby flow will be antigrade, because the retrograde flow has some clinical implications that are very apparent in the next several slides. Now, this is where we're going, and these are 2 videos with technologies that have only been available to us in the last decade. The above one is a percutaneous left ventricular assist device, and you'll notice it crosses the aortic valve, but it drains the blood directly from the left ventricle and propels it through the tube into the ascending aorta on the other side of the aortic valve, and hence you have antigrade blood flow. That blood flow has not received any supplemental oxygenation, so it's simply a ventricular assist device. The device on the bottom is really simply a cannula that has 2 lumens, and I alluded to this yesterday a little bit, and the 2 lumens are put in through the jugular vein, and they will drain both the inferior vena cava blood through these lumens, and here superior vena cava blood. The blood will drain up and out into the oxygenator, the ECMO circuit, and it will pump oxygenated blood. That video didn't complete, but it will pump oxygenated blood through the second lumen into the right atrium toward the tricuspid valve, and it will finish the circuit with oxygenated blood going directly through the pulmonary circuit, which will eventually make its way around into the systemic circuit and improve oxygenation. So depending upon what your needs are, you can either use this with or without the technology on the above. So it could serve as either veno-venous ECMO with a single cannula, or if you need circulatory support, you can combine it with the LVAD above. And this is something we did very novel last year and began a better understanding of this hybrid approach. And we're using this almost on a routine basis now for several indications. I want to describe to you 2 of them. So there's the position of the cannula. There's the red blood, oxygenated blood, going into the right atrium by way of the tricuspid valve. Okay, so let me describe to you 2 cases. And this one was a combined cardiorespiratory failure in which we used a femoral to jugular veno-venous ECMO with a transaxillary impella LVAD. So a young man with a known cardiomyopathy presented with rapid atrial fibrillation, and he was admitted for a elective cardioversion. And as sometimes happens in the clinical world, these patients who have very borderline heart function to begin with decompensate after given sedation for the actual therapy, the cardioversion, and that's exactly what happened. He decompensated. He was a very large man, and in the process of resuscitating him with intubation and chemical resuscitation, he codes. So he had no reserve. So we put, for starters anyway, we put in this axillary impella device, which is a variation of the video I showed you before. It's put in through the axillary artery by way of a graft, and it can continue down, as you're seeing there, through the subclavian artery, down into the innominate artery, through the ascending aorta, across the aortic valve, and directly into the left ventricle, and then the rest of the video is similar to what I showed you before. The patient went on to progress with pneumonia, and this was probably somewhat related to aspiration during the code, and he became hypoxemic. And at that point, we needed to add oxygenation. So our choice was to either convert him from just the impella, that LVAD we put in, to veno-arterial ECMO, which I showed you in the beginning, or do something novel, leave the impella and add veno-venous ECMO, and we did so in this configuration. We put in a cannula into the right internal jugular vein to stop in the right atrium, and we put a cannula through the right femoral vein to stop in the inferior vena cava. We didn't have that double lumen cannula at the time, and that's why we did this configuration the way you see it pictured here. And so we had both cardiac support with the antegrade blood flow through the LVAD, and we had oxygenation through the veno-venous ECMO. And we maintained flows. We sort of maintained them around 5 liters per minute. Each one of them would sometimes vary depending upon afterload and depending upon preload. Both devices do require heparinization, and so we would keep a PTT somewhere between 60 and 80 seconds. Now, what's very important for monitoring is several things. We were monitoring both heart and lung function, but we're also monitoring other organs, including the brain. So, here's the parameters for things like the ventilator with the airway pressures. We would use the typical critical care parameters for lung rest. We don't want peak airway pressures above 25 or 30, so technically they're very low tidal volumes, and FiO2s below 50% and PEEPs below 10. And you can up and down regulate the oxygen on the ECMO circuit, so you can rest the lungs while you're doing it. Echocardiography we would do regularly to determine not only position of the LVAD, but also recovery of heart function, which we'll talk about. And this is a very important tool. This is a cerebral oximeter. It's non-invasive. You put these pads on the patient's head. You can put them elsewhere on the body too, and I'll explain why we would put them elsewhere other than the brain. But this will give you a non-invasive idea of how much blood flow is going up to the head on both the right and left side. So these are very important tools, and I'll explain a little bit more about that as we start to determine recovery of organ functions and efficacy of this technology. So to make a long story short, we had cardiac recovery at least back to his baseline, which, remember, was a cardiomyopathy. So we got him back to his baseline cardiomyopathy, cardiac recovery on low-dose milrinone, and we were able to remove the impella after 2 weeks. But it took another week before his lung function recovered, at which point we were able to remove the ECMO. But as you can appreciate, we were able to take each of those technologies and disconnect them as each of the organ systems recovered. If we were on the classic veno-arterial ECMO, we would not be in a position to do that. Both the heart and the lung would have to recover before you could take that whole circuit apart. It took him a long time afterwards to recuperate. Fortunately, he was a young guy, and he finally left the hospital to a rehab center about a month and a half after his admission. The second case is also cardiorespiratory failure, also with the combination of the hybrid ECMO, VV ECMO, and LVAD, but a little bit different configuration. This was a 47-year-old man who presented with chest and epigastric pain on, of course, a Friday night. He has the usual risk factors and has classic EKG and enzyme for ST segment elevation MI. Goes to the cath lab and has 100% LAD combined with the large diagonal, a chronic total right with left to right collaterals. Gets emergent PCI with drug-eluting stents and a balloon pump with a very good angiographic result. So from here to here. Now, the problem was he didn't improve overnight from Friday night into Saturday morning, requiring increasing vasopressors. He's now intubated, and with the balloon pump and the vasopressors, he's in a low output state. So we put him on veno-arterial ECMO by way of the right femoral artery and the left femoral vein. And unfortunately, this was also a fairly large patient, and the cannula that was put in for the arterial side was too small. It was only a 17 French. The venous was okay, 25 French venous was okay, but the flows were suboptimal, so we really didn't make matters any better. We then took him to the operating room and cut down on the subclavian artery, sewed a graft, and put a much larger flow into the subclavian artery, and kept the femoral vein cannula, and now we had adequate flow. And by echo, his ejection fraction was only 15%. We then transferred him from this outlying hospital to our facility with that configuration. So the first configuration was a 17 French arterial in the femoral artery and a 25 French venous. We then converted to the subclavian artery with a big, large graft and kept the venous. And here's sort of the configuration of how we sewed the graft on the axillary artery. It's not a very difficult thing to do, and we use it quite often in repairs of aortic aneurysms and so forth. So we're familiar with that cut down. Now, by Sunday, he's now on anticoagulation, and the surgery that was done on the subclavian artery is bleeding like crazy. So we have to evacuate the hematoma, and then we decided to get rid of the whole thing altogether because we just couldn't get adequate control of the artery and still maintain good blood flow. So we converted him yet to a third configuration. We now are back down to the groin, and we now put in a larger size cannula. Instead of a 17, we put a 19 in the groin, repaired the subclavian artery, and just transected and oversewed the graft. And his ejection fraction is still low, 15%, so he definitely still needs the support. Now, this was necessary after a couple more days because he is now on the support with this graft, with the impella device, having removed the ECMO because it appeared as though his lung function was okay. But we were disappointed. And several days later, due to a pneumonia with serratia now, we are back to both cardiac and respiratory failure. And now we have the impella device in and with hypoxia. And so now we have the new cannula that I told you about. And we added this cannula into the right internal jugular vein. So now we have oxygenated blood and we have the impella. So now we're on that hybrid configuration with the newer double lumen cannula plus the impella. Okay, so here's a nice picture that eventually may get into publication, showing the dual hybrid configuration of the double lumen cannula plus the impella LVAD. Okay, so over the next week, he had acute kidney injury requiring dialysis. We knew he was going to be in the unit for a long time. We gave him a trach, we gave him a peg, and continued to bronch him every day. Meanwhile, his cardiac function started to slowly improve, and I suspect that was not only due to time, but due to the direct LV unloading with the impella, as opposed to retrograde flow from the traditional ECMO circuit. And we continued with the bronchoscopy and the antibiotics, and we were able to maintain him this way. However, as time goes on with these pump oxygenator ECMO circuits, they clog up. Even under the best of circumstances, after a couple of weeks, they clog up. But they are external, so you can put clamps on the tubes and change out the circuit, and that's what we did after about 2 weeks. Continued with bronchoscopy, and finally his lung function improved enough for us to get the cannula out of his jugular vein. His cardiac recovery is nearly back to normal, and we were able to eventually remove the ECMO cannula, and his kidney function finally normalized as all the perfusion improved over about a month. And finally, he was able to be discharged after, again, about a month and a half to a rehab facility. So what am I trying to point out here? Well, traditional veno-arterial ECMO, as you saw in the very first video, has been the sort of the workhorse and the standard by which we would use this technology for acute cardiorespiratory failure. And it has the advantage of rapid deployment, complete circulatory support, and it's really cheap. By comparison to some of the hybrid technologies I showed you, you're talking about maybe $2,500 compared to $25,000. So it's relatively inexpensive by comparison to the hybrids I showed you. The disadvantage, however, is that, as you saw, it's retrograde flow, so it does not directly unload the left ventricle. And in fact, there's been reports for many years that it actually hurts the left ventricular recovery because it creates more wall tension. And if your heart is trying to recover and pushing blood forward, and you have a cannula pushing 5 liters backward, they're competing with each other, and you create wall tension. And both animal studies and clinical trials have proven that the ability for LV recovery with traditional ECMO is not good. It also has the retrograde systemic flow, and this becomes more important for older patients who have atheroma in their aortas. And you can imagine no matter where in the aorta, whether it's the ascending, the arch, the descending, if your blood flowing up that aorta in a retrograde fashion, you can imagine some of that atheroma may go right up to the brain. And we have seen that on all too many occasions, and mostly the older patients, we put on veno-arterial ECMO and we just shower emboli to the brain. We also have a very interesting phenomenon where you have systemic arterial mixing, particularly as the hearts begin to recover, but the lungs have not recovered. So I'm going to show you a very nice illustration of that. But what happens is you have recovery of the heart, but not the lungs, and so the heart is now ejecting poorly oxygenated blood, and your ECMO circuit is pumping very well oxygenated blood, and somewhere in the aorta, depending upon forces, antegrade or retrograde, somewhere in the aorta there's going to be a zone where they meet, the poorly and the richly oxygenated blood. And you can have what is referred to as a Harlequin syndrome, which I'll show you in a minute, but you have areas whereby upper body cyanosis and lower body non-cyanosis. It's a fascinating phenomenon. I have a great picture to show you in a second. But this becomes important when I told you about that monitor for the cerebral oximetry. We often put that not only on the heads, but sometimes we put them on the arms and the legs, and we can very quickly identify when that syndrome may be happening by virtue of the numbers of saturation going down in the different parts of the body, the head, the arms, and the legs. So this is an excellent angiogram that we did on one of our patients, which will show you the pigtail catheter in the top of the ascending aorta with the dye. So this is cardiac blood going out, and then it stops right distal to the left subclavian artery. It stops there because below it is the ECMO blood coming this way. So you would have poorly oxygenated blood here and richly oxygenated blood here. So if you were to put the monitor on, the cerebral oximeter would be very poor in the head and very rich in the legs. And this is very, very important to pick up because you can have excellent support thinking you're perfusing your kidneys very well, they're making urine, the liver function's improving, and then they're brain dead because you have anoxic encephalopathy, and you can't understand that unless you understand this physiology. Now, when the heart was more or less dead and not ejecting, all of the richly oxygenated blood would make its way all the way down until it would stop at the aortic valve. But as the heart recovers and it starts to pump antegrade, that's where you might get the mixing here or here or here, depending on two things: native cardiac recovery for forward flow, and depending upon things with the ECMO, how much you're flowing retrograde, whether it's 3 liters, 4 liters, or 5 liters. So that's the cartoon, and that's the picture. So really very, very important because we've had too many patients in the past before we appreciated this with end organ recovery, but not brain recovery. So in terms of the hybrid model, its advantages are it's also relatively easy to deploy. It's not that bad. The cannula in the right IJ or the femoral vein, and the percutaneous impella, either through the transaxillary approach or the femoral approach. It does provide complete circulatory support. It has excellent LV unloading, antegrade blood flow. You can couple or uncouple cardiac from pulmonary recovery, and you don't have to worry about this Harlequin syndrome. The disadvantage is it's much more expensive, and as I mentioned before, yesterday and today, you have to make sure these devices are in the right location. The Avalon cannula has to be positioned so the oxygenated blood is aiming to the tricuspid valve, and the impella has to be positioned so that the inflow and the outflow on either side of the aortic valve. If you do all that, then everything is more or less autopilot, and then you have to determine timing of recovery. So in terms of clinical efficacy, this hybrid LVAD ECMO model is excellent. It works extremely well. It's been used now for our purposes of publication in 2 cases. We have several more in our database now since I've done this. And it maximizes both heart and lung recovery with the ability to uncouple them, as each of the timings can be different. Sometimes they are at the same time, sometimes they're not. But as you saw in these 2 cases, both the cardiac side of things recovered before the lungs, and we were able to discontinue the LVAD and leave the veno-venous ECMO for another week or 2 while the lungs recovered. You'll see this probably early in 2016 in the Journal of Thoracic and Cardiovascular Surgery, so you can see those illustrations and you can see the methodology more. I didn't have enough time to go through all the details of the recovery part, but it's very important you understand that. So in the interest of time, I guess I'll answer a few questions. Otherwise, we could do it at the break. Thank you for your attention, and appreciate your attendance. Thank you. Any burning questions now?